Thank you, everyone, for being here today. My name is Dahabo Ahmed Omer. I am your moderator for this amazing session that we have planned. I'm excited to be here because, you know, I've had a couple of these kind of conferences on Zoom, and I feel like we're getting super excellent at doing this now. And I don't know how we're going to get back to normal at some point, but I do wish that I could see everyone in person and hug everybody. And so I hope you're all doing well and keeping safe. And so again, I welcome everyone here today. Please remember to put your microphones on mute. So we're excited to have everyone in today's session. It's going to be exploring the social, economic, and policy impacts of COVID-19. And so I will give the floor to Sarah Cambit, who's a senior advisor and the senior director of UNA Canada, for a few opening remarks. Sarah?
Thank you very much, Dahabo. On behalf of UNA Canada and Balsillie School of International Affairs, especially on behalf of my president and CEO, Catherine White, welcome all of you to today's panel. Thank you, my dear colleague, Dahabo, Ahmed Omer. You have led us, who is leading us today. You have been a profound member of UNA Canada as a knowledge expert. We have been very proud to work together with you and the Federation of Black Canadians. Your leadership reminds us when addressing issues of global health pandemic that good policy must address inequities and inequalities here in Canada, but also globally. UNA Canada and Balsillie School have been partners over a good number of years, and we are particularly pleased at this historical time to be bringing you some remarkable thought and action leaders as we look over the horizon past our current COVID-19 crisis. Anne Fitzgerald, who is the director of the Balsillie School of International Affairs, as well as a professor at the Laurier University Political Science Department, has brought innovative knowledge and leadership to her role, which you will be able to experience through our sessions today. Thank you, Anne and Andrew, and of course, Jessica, my colleague at UNA Canada, and the entire UNA Canada team who have worked diligently to bring you this great panel. Over the years, we have partnered with Balsillie on international diplomacy and development internship program, deploying their talented scholars to UN agencies around the world for career launching placements. Also, UN Canada's landmark programming, the New Diplomacy of Natural Resources, was hosted in the Balsillie's beautiful space on a campus in Waterloo. We are now proud to add this international speakers series. As we come together in this electronic medium, in the spirit of intent of the Truth and Reconciliation Commission's call to action, we acknowledge the traditional indigenous territories on which we gather today, including territories across the country where each of you has joined us from. Here in Canada's capital of Ottawa, where the name comes from the Algonquin for meeting place, we acknowledge that we are standing on unceded Algonquin Anishinaabe territory. As we steer into this wonderful panel and discussion, we should listen carefully, but also attentively. What is it that we're going to take away post the world post COVID-19? And this reminds me of a quote, an expression shared with me by a young professional who used to be our volunteers here, who's now working in health sciences and psychology, who sent this to me, and I thought I'll share this with you as we move into Dahabo's introduction moving forward, and as we launch this speaker series. When people say recovery, you typically think of returning to how you were before your illness, but there is no going back. You do not merely recover, but reinvent yourself. You become something completely different from what you were before. We start with this panel to reinvent ourselves as we move forward. Thank you very much. Back to you, Dahabo.
Thank you so much, Sarah, for setting the tone and setting that context for us and centering us around why we're here today. And so just some housekeeping. I'm just going to explain sort of the framework of the conversation today. We have a few panelists that are going to blow you away and share a little bit about their expertise and sort of their knowledge around some of the issues around COVID-19 and its impacts. And so we will give the panelists each a few minutes to provide their remarks, and we will then go into a Q&A period. Please use the chat box to be able to provide, to just submit your questions, and we will ensure during the Q&A to pose them to the panelists. If you have a specific panelist that you would like to ask a question, just make sure that you put that in your question. Okay, so what I'd like to do is I'll introduce the first panelist. His name is Dr. Alan Whiteside, who was the SIA chair in Global Health Policy from December for about a year in 2000, sorry, I say a year. What I mean is from 2012 to 2018, he's a professor at Wilfrid Laurier University School of International Policy and Governance. And at BSIA, Dr. Whiteside's current research program focuses on interrelated areas of global health concerns. These include shifting burdens of disease, immigrant and migrant health, as well as the economic and social causes and consequences of HIV and AIDS. And so I will welcome Dr. Whiteside to provide his remarks.
Good, thank you very much. Okay, well, let me start by saying this is really bad news. I'm sorry to have to tell you. I haven't seen anything like this in my lifetime, which is longer than I care to say, but shorter than, but I hope it's going to still be longer than it is. This COVID epidemic is really bad news. I think there are a few things that we need to start off by understanding about it. The first thing is that it is a new and deadly pandemic. It's the first pandemic that we've seen really since the advent of HIV in 1981. The second thing, and this is perhaps good news, and people need to take this away with them, is that it does have a very low case fatality rate. It's probably around 1.5 to 2.5%. That means of the people who get this disease, the vast majority will recover, and most people won't even know that they've got it. But otherwise they'll have mild illness, and few will have moderate illness. About 2.5%, about 5% may end up in hospital, and only about 2.4% will die. The third thing is that it's highly infectious. And then finally, the last two things, which I think are really the key for this panel, is that COVID has stopped the world as we know it, and it's going to change the world in terms of how we work and live. And I'm not certain quite how that's going to be, and that's something I would really like to explore during this panel. Just give you a few stark bits of data. Well, I write a weekly blog on this issue. I'll be posting again tomorrow if anyone's interested. When I started on the 15th of February, there were 69,000 cases in the world. On the 17th of June, there were 8 million. There were 68,000 out of the 69 in China in February, 43 cases, just 43 cases in the USA and 9 cases in the UK. On the 17th of June, there were 84,000 cases in China, so much the same. 2.1 million in the USA, 300,000 in the UK. Canada is not doing too badly in catching up with 103,000 cases, and in Ontario there are 35,000 cases. So it is a significant health challenge, and it has become that in a very short period of time. Less than 6 months since the world community was made aware of it. The other point, which I think is also significant, is that there have been relatively few new diseases. And if we start in 1981, we start with the HIV and AIDS, which was a zoonotic disease, and that's significant. It is a disease that was transmitted from animals to humans, took hold in humans, and spread rapidly around the world. In exactly the same way, you have SARS, you have MERS, you have Zika, you have Ebola, and now we have SARS-CoV-2, as it's called. Its official name is SARS-CoV-2, but we call it COVID-19, and that's not because it emerged in 2019, as some people appear to think, particularly south of your border, but because so basically, and that is also a zoonotic disease which came from bats via probably pangolins, probably in wet markets in China. It was certainly, in my opinion, an accidental event. So if we try to understand COVID, we might do well to look at the story of HIV and AIDS, which was the last major pandemic, which started in, was first noticed in New York and San Francisco in 1981. It took until 1983 for the virus to be identified, and treatment was made available by 1996. So it took quite a long time to develop treatment, but it was at an eye-watering $10,000 per patient per year, and the disease was effectively an African epidemic by then, which meant that the majority of people were not going to get treatment. Today, it's a very different picture. Unfortunately, HIV is not something you can recover from, but we can provide treatment for people with HIV/AIDS, which allows them to live fairly normal and healthy lives. So that's the HIV/AIDS story, which developed over the last 30 years. And I think it's really important that we take notice of that, because it is a story which will allow us to perhaps develop and fine-tune our response to the COVID-19 epidemic. Now, when I started working on this, one of the questions that we had to ask was, is HIV and AIDS unique? And the answer is yes, it is. Biologically, it's a retrovirus, and so is COVID. Biologically, it was transmitted through zoonotic transmission, HIV from chimpanzees, COVID, bats, pangolins into human beings. The time frames are different. HIV has a long latent period. You can live up to 8 to 10 years without showing symptoms and before needing treatment. Now, there's something really significant about the COVID time frame, and that is that there's a period of infectivity when somebody is not showing any symptoms, 3 to 4 days. And that is really important, because normally with flus and colds, you start sneezing and you know to isolate yourself. With COVID, it's not the case. There is this latent period, this infective period, when people can infect others and they don't even know they're sick. When we looked at HIV, it was very troubling because numbers were so high. But I have to tell you, COVID is just transforming my thinking now, with over 8 million infections already. The outcome for HIV/AIDS is there's no cure, there's no vaccine, but there are treatments which can keep you alive. The outcome for COVID, well, we've got our first signs of something that will work. And I'm very happy to say that in my blog, I said the most likely first treatments are going to be repurposed existing drugs. And sure enough, we have got one, which is a repurposed drug. Responses for HIV, well, before treatment, it was behavior change. Exactly the same response that we need from COVID. And the behavior changes which are being enforced are lockdowns, hygiene, masks, and really most importantly will be test, track, and quarantine. You couldn't do that with HIV because it would be very opposed, but you can do that with COVID because you can recover from it. Transmission mechanisms, it's respiratory, and this is really bad news because it means it's very easily transmissible. I don't think we should carry on worrying too much about surfaces. I mean, I'm appalled when I see people going into deep clean schools in England which haven't been occupied for 6 weeks, when we know that the virus will last no more than 72 hours. Location is important. For HIV and AIDS, it's Southern Africa. For COVID, it is the USA. Russia, Brazil. Not in Africa yet, and I'm really going to be interested to see what happens. Same for location by demography. HIV, younger people, women more infected than men. Unique for COVID, older people, and particularly males, more males than females, who are being worst affected by this. So it is, both diseases are taking out a particular risk group in a population, and that is good and bad news, because it does mean you can target what's going on. I would like to just say a couple of things on the impact. When it comes to HIV and AIDS, we did an awful lot of work on this, and we were able to track the impact that this disease had in terms of life expectancy, where in Zimbabwe it fell from 60 to 37 years, in terms of economics, in terms of orphaning, and so on and so forth. We really don't know what the impacts are going to be of COVID, but they are going to be serious. Of that we can be certain. So the consequences of COVID, it's going to take out a number of people in our population, predominantly older people, or people who, and particularly older people who have comorbidity, which means they have another infection. That's sadly what is going to happen to these people. We are going to see some really interesting public health responses, which are going to ride roughshod over human rights, I suspect, because we're going to have testing, tracking, and I think mandatory quarantine. It's really shown up the lack of leadership in both the United States and, I'm afraid to say, the World Health Organization, which has been sadly lacking. And finally, the lockdowns have been extremely damaging to economics and psychology of the population, but the economic impact is going to be absolutely horrendous. I'm sorry to say. I'm glad I have a university pension, and that's all I needed to say this evening, so thank you.
Thank you so much, Dr. Whiteside, for those insights, and I'm sure that there are going to be some important questions to you in a little bit. Our next speaker is Dr. Sue Horton, who's a professor of health economics in the School of Public Health and Health Systems at UW. She's received her BA from Cambridge and her master's and PhD from Harvard, and specializes in health, nutrition, and labor market issues in developing countries. Her research focuses on health economics and health policy, particularly on nutrition and public health, and more recently also cancer. She has worked in over 20 developing countries. Dr. Horton, the floor is yours.
Thank you so much, Dahabo, and I'm glad so many people were able to join us this afternoon, and I'm looking forward to your questions and comments. It's great that Alan led off with such a comprehensive overview, and since I also work on health, I thought I would talk about a couple of projects that I'm involved in related to this topic. So at the time when the pandemic first emerged, I was working, well, I'm still working on the Lancet Commission on Diagnostics. So this is a commission that's going to report in the Lancet probably next summer. And just to define diagnostics, you know, these are tests that are used to help a clinician diagnose the condition that the patient has. And the two biggest kinds of diagnostics are in vitro diagnostics, you know, laboratory medicine, and medical imaging. So that's what we are focusing on in the commission. Okay, and that obviously ties directly to COVID, because testing has been such a key focus of attention and of great concern, especially earlier on in the pandemic, when few labs were geared up to provide sufficient tests. And it's still a huge issue in the countries in Latin America and Sub-Saharan Africa and South Asia to get enough of the population tested. So when we started the commission, you know, obviously we had no idea that the pandemic was going to occur. We were halfway through already when, you know, these first news reports came out. But we had already focused on the fact that diagnostics are highly under-resourced. So when people think about getting ill, especially if they are poor people who are not covered by insurance, their main concern is usually, how can I get treated? And actually being diagnosed is costly. And if poor people have to make the choice between, can I be tested, or can I just go with a presumptive diagnosis and pay for my treatment, they will often choose the latter. And if you don't believe me, ask someone who owns a dog or a cat in Canada, which are not covered by insurance. You know, and when the vet asks you, oh, do you want to do this blood test? You go, no, my dog doesn't have heartworm, I just need the pills. You know, and it's the same thing for malaria or fevers in tropical countries. So another aspect of that is that people don't often see the laboratory expert, you know, working behind the scenes to do the test. You know, they drop off their blood sample and then have no idea really what happens until they get the results, and it may take a while. So this is an aspect of medicine where you don't directly meet the person who is working to help you with your health. You know, it's unlike seeing a surgeon or, you know, seeing a family practitioner. And so that's another reason why we think diagnostics are under-resourced and underappreciated. But then that has really, really bad consequences because people aren't aware that they are ill and may spread the infection, as is happening with COVID. If people try and treat themselves, you know, with something that they think that will work, they run the risk of having adverse consequences. And there's a waste of economic resources for taking medicines for a condition that you don't have. And another bad outcome is antimicrobial resistance. If you simply take antibiotics to treat something that you think you have, but in fact you don't have that condition, you know, then you're making it more difficult for people in future to be able to use those antibiotics. Access to diagnostics, as I've mentioned, is very poor in poorer countries and for more marginalized households. Some of the research we've done for the Commission suggests that between 10 and 20% of people only in the poor, low and lower middle income countries have access to very, very basic diagnostics within 2 hours walk of where they live. So in countries like Ghana, where it's mandated that during pregnancy, women should be tested for hepatitis B and for glucose intolerance, you can imagine some poor pregnant lady walking for 2 hours to the health center and then finding that the test is not available that day. The situation is even worse for imaging diagnostics. Less than 10% of the population in low and lower middle income countries have access to even basic ultrasound within 2 hours of their house. So you can also imagine that access is differential by socioeconomic group. Richer households find it more easy to get tested and therefore get access to treatment, which may be covered by national health insurance. But for poor households, they don't even get past the gate. They can't reach the place to get diagnostic tests. They can't afford diagnostic tests, and hence they won't get treatment. So how can we achieve universal health coverage, one of the Sustainable Development Goals, without better access to diagnostics? So this is going to be a key message of our Commission, that better access to diagnostics is going to be essential, and without it, you can't have universal health coverage. You know, and we're totally aware of this through the COVID pandemic, because access to testing in Canada and particularly in the US has been such an enormous problem and issue. I read a heartbreaking story from a woman in one of the magazines who said that the day that she finally was notified that her husband could get his COVID test was a day when he was on life support in the hospital. Access was that difficult. So what next? Will the lessons we have learned about diagnostics from the COVID experience be forgotten? Will diagnostics retreat back into the shadows? Or can we help through our Commission and through other related initiatives to put diagnostics higher up on the agenda. I certainly hope so, but so watch this space. And maybe I'll finish up by talking a little bit about the Sustainable Development Goals. I already mentioned, since this is an event for UNAC, so obviously the goal for universal health coverage is tied to the success of what's going to happen to diagnostics. But at the same time, the COVID pandemic really is going to threaten the Sustainable Development Goals. The amount of money that is going to be required for vaccines is enormous. I think there are something like 3 different consortia, and one of them just raised, is in the process of raising $8 billion for vaccines. But think about that as a proportion of global national income. So the amount of funding that was needed to attain the Sustainable Development Goals was already very ambitious. People estimated it was of the order of 7% of world income annually every year for 15 years to achieve the Sustainable Development Goals. The amount of funding that's going to be diverted simply to coping with the pandemic is going to make that very difficult. And in the area of health, what we already have seen is that the emphasis on the COVID and people's fear and concern about going to the doctor and the disruption that's been caused to the health system has already had devastating effects on immunization. So measles is likely to resurge. TB treatment, according to a colleague of mine, has been set back 5 years because nobody with a respiratory infection wants to, go and be tested for TB. Everyone is concerned about COVID. So we're all very concerned. I don't want to be too negative. Alan was a great presager of doom and gloom. But just to finish up, what's going to happen to the UN architecture? We've already seen WHO under threat, losing funding at a key time in the world global health situation. So there are really big issues on the table, and I look forward to hearing the rest of the distinguished panel. Thanks, Dahabo.
Thank you so much, Dr. Horton. It's not fear. I think, like, even for me to sit here and listen to what you both have said so far, I mean, it's information. It almost takes away that anxiety just by hearing it. So yes, it's scary to know that we're in difficult times, but I think it's important to have this conversation. And I'm glad that you bring up sort of the Sustainable Development Goals, and they were established as a blueprint to sort of achieve a better society for our people, whether it comes to poverty, inequality, climate change. But it's really interesting to see that what COVID-19 can potentially do to that blueprint. And so thank you for mentioning that, and I'm sure there are going to be some questions around that. So our next speaker is Michael Pearson. He is the branch head of the Office of International Affairs for the health portfolio within the Government of Canada. In his current role, Mr. Pearson is responsible for setting and advancing the federal health portfolio international priorities to support both domestic health interests and foreign policy objectives. Mr. Pearson has previously held senior executive level positions within the Government of Canada at Health, Privy Council Office, Department of Fisheries and Oceans, and Global Affairs Canada. Mr. Pearson holds an honors BA from the University of Toronto and a MA from Norman Paterson School of International Affairs at Carleton University, Ottawa. So Mr. Pearson, the floor is yours.
Many thanks, Dahabo. I thought I was after Peter, actually, but happy to go before our WHO colleague, who I think can speak, I'm sure, quite a bit on the WHO. I'm going to try to take a slightly different perspective based on my experience, including, and most importantly, my current role as the head of the International Affairs Group and the Health Portfolio and Government of Canada. So my remarks will be primarily based on sort of that public policy lens. and the sort of the way that I've been experiencing it during this time. I do want to indicate I'm happy to always happy to be part of a United Nations Canada event. My family had a long history with this organization, so it's always great to be able to participate. And I want to thank White and all the team for that opportunity. And also, of course, thanks to the Balsillie School and UN for being a sponsor of this event as well. As I'm speaking, just one forewarning, if you hear a very loud noise, that's my 19-year-old cat who is totally deaf and yowls incessantly as a result and never hears itself, but we hear her constantly. So please don't, I hope try not to be distracted if she does that, and I hope you won't either. There, you just heard a bit. Okay, so I do appreciate this opportunity to meet virtually. Certainly my experience in diplomacy suggests that the downside of everything happening virtually is that there are so many things you cannot do, so many hallway conversations you cannot have, so many issues in diplomacy get resolved, frankly, out of the formal room where an event is happening. And that's been a real challenge, I think, for not just Canada, but for the international community more generally, the global community more generally. On the other side, though, it allows a lot of people this format to participate, to listen, and to be engaged in these discussions. So from that standpoint alone, I think it is a great thing. So let me start by saying I'd like to put the pandemic a little bit in context. Al said something a bit about this before. You know, we have what almost 9 million cases now around the world, almost 500,000 deaths. That's about 100 times less than the Spanish flu of a century ago, but also 100 times less than the smallpox, particularly in the 16th century. Well, smallpox existed for a lot longer than that, as you know, about 400 times less than the Black Death in the 13th century. But if you come to the modern period, the 21st century in particular, clearly this has well outpaced, SARS and MERS and Ebola, H1N1, which I was involved in when I was at Health Canada over 10 years ago. So in that sense, I think we need to recognize that although we've had a number of historically, it's not as large, clearly not over. In context of recent times, it is much more significant. And I think that is important to note and want to ask ourselves whether that may portend for the future. One thing I think is important to note also about all of those, both in many centuries ago and much more recently, are the commonalities. With the exception, I think, of smallpox, and I'm not a scientist here, but from my understanding, what's interesting is that in almost all these other cases, there is a zoonotic origin. So, Dr. Whiteside spoke a little bit about how this might have emerged in a wet market in Wuhan. But in fact, all the other ones are also, have that kind of origin. And I think when we talk about learning lessons, which will be the key part of my presentation, one of the things we need to think about is a whole One Health question, and how do we attach more vigilance to it than maybe we have today. The second commonality is the spread through travel. And by connection to that, the higher impact in urban settings where individuals are closer to each other. These seem like obvious things, but it is something that we need to think about when we talk about commonalities and lessons learned. Because, for example, early on in this crisis, there was some discussion about the fact that travel should not be restricted, that was not a means of preventing the virus or keeping the virus from spreading. And now, of course, we know that's not true. What I think is common in all of these cases, and I'll speak then most specifically to the current one, is how the uncertainty of the science, how much uncertainty there is, and how that uncertainty continues, even as we learn from a scientific basis a number of things. As a policymaker, decision maker, the key thing is asking yourself the question of how science informs decision making, policy decision making. And I think the COVID crisis has demonstrated very clearly about how science keeps evolving and understanding it, and how public health measures, which is the focus I've been engaged in, has tried to adjust accordingly. I raise this because there are so many, as is always going to be the case, armchair quarterbacks or, hindsight 2020 types, who say, how come you didn't do this first? How come you didn't do that, et cetera. And I think a lot of the reasons that, when we make an assessment of how the international community, the global community is managed, how Canada's managed this, we need to be clear in understanding how the science kept evolving. So just give you a few examples. We talked early on, there was a lot of discussion by public health officials about the spread was done through droplets. Only more recently has there been a much more of a significant discussion about the aerosolized way that it happens. Instead of droplets which drop straight to the ground or onto a surface or something like that, now we've been talking in a more recent way about it, how it hangs in the air or stays for a longer period of time and can be transmitted that way. The same thing about how long it lasts on a surface. If I recall earlier discussions way back in January, February, where we weren't sure that it lasted long when it landed on the surface. Now we're talking about Dr. Whiteside 72 hours. People say more than that, up to a week or more on a surface. A lot of discussion early on about the fact that this was symptomatic, that people were symptomatic, and that's how you could tell that how the virus was spreading and who had it. Then we moved from that to understanding there was perhaps more pre-symptomatic cases. Now we're talking a significant number, up to I see 30% in some cases, or some theories or analyses, scientific analyses, 30% asymptomatic. So when a comment is made, how come you didn't stop everybody at the border in February, kind of thing? Well, we didn't have any idea or any real sense, based on what the scientific evidence at the time was telling us, that asymptomatic carriage was so significant. And I think that's really important in trying to understand, again, lessons learned. Also, how it spread, the knowledge evolving over the degree of super spreaders and how significant they can be. And these are often the people who've traveled from one location to another. I think it's commonly understood that the significant reasons for the growth of the virus in Italy was as a result of an Italian came back to the Venice area or the Milan area from China via Germany, was out doing a lot of social things for 72 hours before he became an obviously symptomatic carrier. And how many people, 600 or more, that he may have infected during that time. And then the stories are out there. Are kids exempt? Are kids not exempt? What is the science telling us about that? Are they okay? Are pets? Is my cat a worry? Is cardboard a problem? Every time I get an Amazon package, I have to worry. Shopping bags. We can't carry shopping bags into grocery stores. There's just so many bits of information out there, which I think when you look at them all together and you see the evolution of them, I think it makes it a little easier to understand how it is difficult to apply a number of public health measures in a way that looks like you're trying to meet the needs that are up there. So when we talked about things like physical distancing, and I always prefer using the word physical as opposed to social distancing, non-travel, washing your hands, self-isolation, and then most recently the ongoing mask debate here in Canada. Trying to, people say, how come we didn't put masks on 3 months ago? And I know a study just came out today saying that seems to be evidence that societies where masks were worn in much earlier time and much lower death rates. That may be true. But try to imagine in early February or mid-February, they all had to wear masks. There's that sort of culture. It's not just a matter of scientific information evolving when you're talking about public policy measures. It's also the cultural environment that you're in and the acceptance of society. And I want to come back to that also at the end of my remarks about how important it is to understand public acceptance and how you get there. So all to say that public policy, as I said, highly fluid, scientific information, making public policy in a context of highly uncertain, evolving situation like this, it can be a very significant challenge. So let me talk on that basis of six lessons that I think I've been learning and maybe others have been learning. We can talk about probably many more than six. And I'll start. The first one is Teresa Tan, our Chief Public Health Officer. She said a while ago, quote, when you've seen a pandemic, you have seen a pandemic. Her point being that no pandemic is like the ones before it. There are some things that are common, but there are things that are not common. I mentioned earlier about the travel and trade advice that was given out early on. Don't separate the two. Don't prevent travel from happening. Now everybody's talking about making sure travel is restricted, but trade continues. So understanding that, you know, past experience doesn't necessarily tell us all the ways that we to work in the future in addressing what we know will be inevitable, whether it's a second wave in this pandemic or other pandemics that will come in the future. Second lesson, using information technology. I think everyone's been hearing about the use of apps, etc., for contact tracing and tracking and so on. But, you know, the use of information technology for surveillance, for early warning, the blue dot technology, that's GFIN, which is another form of surveillance technology. There are a number of things that have come out as a result or have become more known as a result of this crisis that I think is going to be very important for us in the future. You know, how do we harness information technology more effectively in fighting any future pandemic? The third thing would be scientific research, understanding both the importance, I guess, and limitations of scientific research. I think we've seen in an unprecedented way, and again, I'm not a scientist, but, you know, an unprecedented way, the degree to which there's been a lot of science and data shared, a lot of it not peer-reviewed in the traditional way, but out there. And you would argue, on the one hand, better to get information out about possibilities, about what the science is telling us in order to inform decision-making. There are obviously risks associated with that too. I think the most good example of that is the situation with that therapeutic hydroxychloroquine. Hydroxychloroquine, I hope I pronounced that correctly. Which everybody thought, and I'm not even talking about what the White House said about this. I'm talking about a lot of other people who thought that seemed to be, you know, a therapeutic which should be helpful, and now we're all saying it's not helpful, and everybody is not using it or it's being debunked. So. And yet go back 2 months and there was a lot of discussion about the value of that, as a treatment. The other thing I would learn about scientific research, or what's important about it, is how we would link the knowledge of scientific, of what we're being told about scientific research to ensuring access and benefits. And this will be particularly important in the context of vaccines, because it's not just about the, you know, I quite like the fact, frankly, that we have all kinds of activities, all kinds of companies around the world involved in vaccine research and development, and that maybe we'll get one sooner than everybody thinks is possible, but we have to make sure that they are widely available and widely distributed, widely accessible across the international and global community. That would be, I think, a key thing, and you know, Peter may say something about that role of the WHO in that regard. I would argue it's a very important lesson being learned too. I talked already about the One Health approach. The fourth example, you know, we need to learn more about how to adopt the One Health approach, understanding virus origins and transmission, working with FAO, WHO, and the OIE, as it's called, the World Organization for Animal Health. I mean, this is, some people are quite aware of the One Health approach and discussed it. It is a really important issue for a number of reasons, and I think we need to be more focused and put more scientific research and activity and analysis into that. Fifth, public health institutions and capacity. I think one thing that really important thing we've learned, it's not just a matter of not enough PPE or stockpiling of that, or about hospital capacity. It's also about public health governance. You know, having the right sort of institutions in place, having the right governance in those institutions in many parts of the world. You know, we all are aware of the challenges we faced in Canada, but we also know how significant in other parts of the world the lack of proper public health governance, the negative impact that has on the ability to fight the virus effectively. And I think there's a lot of things that we need to learn about how we can, at the global level, improve public health institution building. And then lastly, and I would say probably even most important of all of these things, and I come back to the comments I've made about how people adapt or do things, the importance of risk communications. I think what really happened in Canada that I think is been valid and valuable, whatever you might say about when advice was given and how it was given and the uncertainties, it's the constant public health officials, both the federal level, territorial level, provincial level, local levels, municipal level, every day. And we still see that, of course, that messaging getting out. I think we've learned from Ebola and other things how important it is to build community trust in order to ensure compliance with public health measures. And I would say that one of the good outcomes, or not outcome, but one of the good examples or experiences we've been having with with this virus has been the effectiveness of public of risk communications, and how important it is and how valuable it's been. There was a public opinion survey, I think, that just came out today or yesterday, saying that 2/3 of Canadians say they don't want to reduce the degree of social or physical distancing from 2 meters. That's a huge degree of compliance. To the fact that 2/3 of Canadians would say that now in the midst of recovery processes across the country, I think is a demonstration of the recognition and the willingness to comply from that's a Canadian context, obviously not the same issue south of the border. So this will be very important in the future for vaccine acceptance as well. The constant ability for public health officials to be risk communicating, to be telling Canadians, and I would argue this is important internationally, obviously, to be able to get that message across, to create that degree of community trust, which I think leads to adherence and compliance with public health measures. So thanks, I'll leave it at that. So much more to talk about, but happy to be able to talk about it when we have questions and answers. Over.
Thank you so much, Mr. Pearson. You know, a lot of what you said definitely resonated with me, but the two things that I caught that they're still staying with me is, obviously, I have been personally worried about my cat almost every single day. I've been checking him out every single day, and you think he's freaked out by the amount of times I investigate him, as if I could tell just by looking at him what's wrong. But you know, it does speak to this you know, life of uncertainty that we're in, and you know, this not knowing when this is going to end, and I don't even know what the end actually looks like. And so you're right, I think we have learned a lot in the past couple of months in this changing environment that we're in, and that we're really in the fight of our lives right now. And so I think it's a perfect time to bring Dr. Peter Singer, who's a special advisor to the Director General of the World Health Organization. In his current role as an advisor, he's responsible for helping to implement and advise on policies and actions taken by the World Health Organization. Before joining the WHO, he was at Sun Life Financial Chair. He was a Sun Life Financial Chair and the director of the University of Toronto Joint Center for Bioethics. In 2011, Singer was also appointed as the Officer of the Order of Canada for his contributions to health research and bioethics, for his dedication to improving the health of people in developing countries. He's also studied internal medicine at the University of Toronto, medical ethics at the University of Chicago, and public health at Yale University. And lastly, but definitely not least, he's also studied management at Harvard Business School. So Dr. Singer, the floor is yours.
Well, thank you so much. And I just wanted to echo Michael's comments about how wonderful it is to be at this United Nations Association Canada event. I joined the United Nations late in life, but what an amazing organization it is, and how important multilateralism is, and how proud I think we can be as Canadians of the echoes of multilateralism and indeed support that we have for it today. And that's actually the focus of my remarks. I want to just reflect a little bit on multilateralism, on the World Health Organization, on Canada, but also want to just say up front how humbling it is for me to be on this panel with all these distinguished panelists, and really look forward to the audience questions as well. So as a Canadian living in Geneva and working, as mentioned, as a special advisor to Dr. Tedros, the Director General of WHO, I often get the question, what value does WHO offer to Canada? And my answer is always the same, that WHO is essential to Canada. In fact, if WHO didn't exist, the world, probably with the urgent support of Canada, would be rushing to create it. That's not to argue that the institution is perfect, and I'll come back to that shortly, because it's very important, as Michael said, to learn lessons. All of us need to be learning lessons throughout this pandemic. So why do I think WHO is so important to Canada? Because in an interdependent world, global threats require a global response. Bluntly said, none of us is safe until all of us are safe. And that means we require multilateral institutions that operate internationally, reaching across borders to coordinate action support national and regional responses, fill gaps, and these gaps, unfortunately, are many. For example, since January, WHO has shipped tens of millions of pieces of personal protective equipment, medical oxygen, diagnostic kits to many, many countries around the world. It has mounted more than 80 surge missions to hotspots in support of governments, trained more than 3 million health workers around the world in very important topics like putting on and taking off personal protective equipment, which actually protects the lives of those health workers. And these actions have saved many lives by acting globally and supporting the domestic action of governments. In the issue of leadership, having observed it up front, I've been extremely impressed by the calm, principled leadership of Dr. Tedros under, as was mentioned, a lot of pressure in what really is one of the worst public health crises, and I agree with Alan on this, probably in a century, I would say. Dr. Tedros has consistently talked about the importance of global solidarity and talked about the virus not exploiting the cracks between us, and consistently talked about protecting the most vulnerable amongst us, which of course is a hallmark of the United Nations system. And so the first part of my answer to the question about WHO, multilateralism in Canada is WHO exists to help where no single nation, no matter how powerful, can go it alone. And this particular argument, of course, tends to resonate with Canadians who, as citizens of a middle power, have historically embraced the values and virtues of multilateralism. Still, we live in a time when international institutions operate under unprecedented challenge, and it falls to WHO to be able to demonstrate its efficacy. And that's why in May at the World Health Assembly, the Director General proposed, the nations of the world resolved to conduct a independent, comprehensive evaluation of the international response, including but not limited to WHO's performance. We actually would conduct an after-action review in any major event. And I think this is important, and I think it's an important mark of humility as well that we all need to show. But for Canada, WHO's value is not merely limited to this strength of this multilateral response. And this is the point I want to make. There's also direct and practical benefits that support the efforts of federal, provincial, and local public health officials and policymakers. And of course, this has been known for decades in the case of tobacco control, in the case of selection of the strain of the flu virus. WHO's technical guidance has been critical, the flu vaccine, based on selection of viral strains. But with respect to COVID-19, there are equally compelling and pragmatic benefits to Canada that are accessible through WHO. First is the issue of the technical guidance on public health matters related to COVID-19. Physicians, public health officials, policymakers, scientists rely on such technical guidance, as do others around the world. And Michael spoke very eloquently about the evolution of science, and I would echo that. As our understanding of the science evolves, that guidance will be updated, revised, even significantly revisited, and just want to acknowledge that this can be frustrating. But in dealing with a novel virus, where our understanding is literally reinvented day by day, there's no alternative. We're learning as we go, and the technical guidance is essential in shaping Canada's response. So first, a direct benefit to Canada is the technical guidance. Second, WHO facilitates an enormously valuable and high-level exchange of information and lessons learned. Each week, health ministers from around the world and senior public health officials come together to share perspectives and experiences. These include some of the most challenging frontline issues confronting countries, such as testing, contact tracing, and especially the things that happen as one starts to reopen, where even the countries with the best responses see resurgence in very particular scenarios, and they address that in very particular ways. And sharing those lessons is critical. The lessons learned through these events are vital, and there are also technical networks of public health officials that are WHO-based to learn lessons at that level. Thirdly, WHO is playing a crucial role in scientific response to the pandemic, accelerating the development of diagnostic tests, therapeutics, vaccines. These are the tools that Canadians and all others are counting on most desperately. But just as importantly, WHO is the vehicle, and this was mentioned as well by Michael earlier, not only to help with partners to accelerate the development of these vaccines, but also to ensure that they're equitably distributed. And this is really critical. And that equitable sharing, of course, avoids the prospect that these vital global public goods might be reserved for some to the detriment of others. So as a Canadian working at the heart of the international response, I'm a daily witness to the efforts of WHO colleagues who are working around the world and around the clock to confront COVID-19 and to protect the public health of us all. I recognize that WHO faces real scrutiny and sometimes even cynicism, as do many of our institutions, and indeed as does the multilateral system itself. At the same time, I can say with absolute and full conviction that Canada gains enormously from its contributions and participation in WHO. The relationship is not only vital to the exercise of Canada's global leadership, but it's also central to our successful response to the pandemic right here at home. So thank you very much for your attention. Again, an honor to share this panel with these colleagues, and very much look forward to questions of everybody on this video call and the discussion period. Thank you so much.
Thank you so much, Dr. Singer. There is such a wealth of knowledge on this panel. I'm mesmerized by all of you, and I'm really glad that you mentioned a few things, you know, around how this is a global threat, and we're going to need a global response to that, and sort of the work that WHO is currently doing to sort of support the entire world right now. And so I can understand the pressures that are there, but also sort of the responsibilities that you have around that. And so thank you for explaining that. You know, we hear about WHO all the time, but I think you've done a really great job at speaking to the vehicle that sort of that role that you play in the broad scope of this virus, and how we're going to be able to deal with it at some point. And so this is the time for our audience to step in and ask questions. And so I do see that there is a question here. So I'll put it out, and any of the panelists can respond to this question. So I see that moving forward, do you think that there is an essential step that must happen in order to move forward effectively? What do you think is the must do right now in any of your areas or perspectives?
So I think the thing we need is more information. What is puzzling for me is why we don't have an epidemic in Africa yet, and I wonder if it's time or it's more than that. The other thing which puzzles me, sorry, I'm giving you questions which I think we need to think about, is the successes of, say, South Korea and other parts of the world, are they replicable? In the UK, our chief government scientist, Patrick Valence, was talking about the fact that we would probably have 80% of our population infected before this was over. That's clearly not going to be the case. Peter, it'd be interesting to hear you say on what you think the percentage is, and or perhaps also what you think we need in terms of herd immunity.
Yeah, thank you. Just to jump in, and thank you, Alan, for that segue, and thank you so much for your earlier very, very thoughtful comments. I agree with you. Maybe what I want to say at this point is to remind us that even though we've been talking about the science and many other things, the heart of the public health response, and Ellen actually mentioned this, is testing and isolating cases and tracing and quarantining contacts. That is the shoe leather epidemiology, or the basics that are the very, very heart of that response. It requires a public health workforce, it requires commitment, and it requires, as Alan said, data and information on where these hotspots are occurring so that activity can be continued. That's what the most successful countries have done. And I just wanted to remind us of that shoe leather basic epidemiology that we tend to forget, because that's how we will learn to accommodate and live with the virus, maybe not in a normal way, but in an accommodating way for the months to come, until and if there is a vaccine or a highly effective therapeutic. So Alan, that would be my response. Many things we could have said, I'm sure the same as you, but to me, that's really the heart of the issue as we move forward in a very, very practical, pragmatic, and common sense kind of way. And also, of course, the things that individual Canadians, and you mentioned communities, can do, but I won't take more time to list those now. I'm sure others will come to them.
Dahabo, if I might add a couple of comments.
Yes, please.
So, I mean, we focus a lot on the short run to-dos, you know, to get this pandemic tamed. But there will be longer term things also, and let me mention two of them. The pandemic has firstly shown how vulnerable the elderly population living in long-term care homes are. And I think that's been true in the UK as well, that the majority of deaths have occurred in those situations. I also read something today suggesting that we don't expect the vaccine to be all that effective in older people, because their response, their antibody response to the vaccine is not as strong as for younger people. You know, so there will be issues to do with the vaccine, but I think there are also bigger issues about taking care of our elderly and vulnerable population. I think we've learned that having older care homes where there are 3 and 4 residents sharing a room is disastrous, where infection can reach this group, and doesn't have to be COVID, even the flu. So I understand that's one big issue. Another big issue is how the marginalized workers, the underpaid workers, in the personal care workers, both in the homes and then going into individual people's homes to care for them, the fact that they are so underpaid, that they are forced to work multiple jobs, and thereby transmit infection between care homes. I think we have to long run think about those issues. So that's one whole set of questions. And the other big one, where I'm also doing some work, is the mental health issues related to the lockdown. You know, I think it's been totally unprecedented, and we all fear that there's been an increase in domestic violence, that there are mental health issues for children who, you know, in Spain were not allowed out for 8 weeks, and that there's a lot we can do. I mean, I have a PhD student who's doing some work on disability and on how we have to think about messaging and trying to reach those living with disabilities, or particularly mental issues, as to how to inform them what's happening and to empower them, you know, feel less endangered by the pandemic. Thank you.
Thank you so much to both of you. We're getting a lot of questions in, and hopefully we can get through all of them. So the next question is, we have many pundits have warned about a food crisis that could occur because of the economic impact of COVID-19. Is there a food crisis coming?
Well, not in Canada. You might have to have less choice. You're not going to starve. In much of the rest of the world, I mean, for example, I was reading yesterday in the paper, the one of our local superstores dropped the numbers of the variety of a particular soft drink from 48 choices down to 7. So, you know, in Canada, you're not going to starve. I think in much of the rest of the world, there is a very strong likelihood of it, particularly in the urban and peri-urban areas where it's not just food that won't be available, but there won't be incomes available.
Absolutely. I don't know if Mr. Pearson has any comments he'd like to add.
Thank you. I'm in no way an international scholar on this. I do know the World Food Program has made it very clear that there are major risks to significant parts of the world related to in the context of a food crisis, and a lot of that is and this is I think it's the bigger question. You know, what are the unintended or the side effects, what the right word is, of the public health measures you have to take to ensure people's that people don't get this virus. And there's a lot of discussion about the mental health impacts of health measures which force people to stay indoors. We're seeing in the context of food, in particular in Canada, I mean, I think Alan's right, but the temporary foreign workers that people have, you know, that most Canadians, I think a lot of Canadians don't recognize the degree to which a lot of the local produce that get fruit, vegetables and fruit and so on are as a result of the fisheries as well, by the way, the degree of which we bring in temporary foreign workers from many countries, particularly from Central America, but not only there, Asia as well, who provide this invaluable service. Many of them we're finding, and it's not surprising given our experience with long-term care homes and so on, that in confined quarters, in confined spaces, the infections are going up dramatically. So, you know, now trying to work out an arrangement with Mexico to ensure, and it's, by the way, not just with countries where these people come from, but in fact with the farmers here in Canada and how they, you know, their normal practices of housing temporary foreign workers when they do this kind of work. You cannot, you know, there has to be new normals, and I think a lot of I don't, you know, whether it will be a food crisis or not, I'm not qualified to say here or elsewhere, but I do think a lot of how we manage food is going to have to learn lessons from the experience we've been in.
Yeah, if I could just jump in for 30 seconds as well. I think it's important, yeah, thank you, Dahabo. I think it's important for people to realize the virus kills three ways. It kills directly, and today we're up to almost 9 million cases, and as Alan was saying, almost 470,000 deaths. It kills indirectly from lack of access to medical services or health services, and we really see this. And often that's people are afraid to go to the clinic. It's not that the services are not available. And then, and that happens, by the way, in every country in the world. And then thirdly, it kills through livelihoods, through hunger, through famine. This is a crisis of lives and of livelihoods. And it's possible that the numbers get bigger as you go into those concentric circles. It's also where the multilateral system has been very much working together. And if I may say, for example, where Canada has very strongly supported the global humanitarian response as part of its commitment to multilateralism, and this kind of strong support, I think, is very much appreciated and saves many lives.
Thank you, Dr. Singer and Mr. Pearson. So we do have another question, which is a question I have as well. Where do you think we are in Canada and in the world when it concerns the second wave? And I'm sure any one of you can probably take that question, but where do you think we are in the second wave now?
I think that's the wrong question. I think that's the wrong question. Because basically what's going to happen is it's going to go something like this. If I could just show you, there'll be wavelets. It'll go up and down. So the question is not whether or not there will be a second wave, but how serious it will be. And I think it's not going to be as bad as everyone feared, because this has been a real wake-up call to the world. But I do think the question isn't about the second wave, it's how big it is.
And it's important for people to
diagram. I'll go to Mr. Pearson, who had his hand up, and then I'll come to you, Dr. Singer.
Of course.
I don't think I'd have much substantive to add. Alan's right. It's a matter of how many waves and to what degree of severity. I do think there is some confidence in thinking that lessons being learned immediately. I mean, I think we have more Canadian companies producing personal protective equipment than we ever had in the history of our country, and they'll probably produce too much of it now. But maybe that's not going to be a bad thing, because there, you know, there was a comment I think someone made earlier about Africa, and and when's it going to hit Africa, or how bad is it going to be, like we're seeing in Latin America now? And I think that's still the first wave going through. So there's going to be, I think Alan's right, that there'll be reduced numbers, but I'm actually more worried about the possibility of other infections. Everyone assumes that pandemic happens and then we're going to have, I remember when I first started a year ago at the agency, and I just started there 10 years after being at Health Canada, and the common conversation was, pandemics, virus pandemics like this come once every 10 years. Well, maybe we're talking about once every year, or 2 years, or who knows. I mean, I think that's, if we're going to be learning lessons, that's why the One Health thing is so important in my view. It's going to be, how do we manage what could be a much more frequent pace of pandemics than we're historically used to, and with a much more global reach, given the nature of how people can move around the world as easily as they do right now. So it's a bit gloomy to think that way, but I think that's what we need, the way we need to be thinking. Over.
Thank you. Dr. Singer?
Thank you. I just wanted to say it's far from over. And those peaks in those waves are because of community transmission. That's why it doesn't go down to the baseline. And I think it's important for everybody to think what they individually can do and actually to do it. Don't go to work if you're sick. Cover your cough and sneeze, wash your hands, wear a mask if you can't physically distance, if you're outdoors or if you're at risk. And there's simple things that we can all do. We have control over this pandemic. And Alan mentioned the behavioral things, and they're extremely, extremely important, because it's the community response and it's the behavioral action on the part of people like those on this video conference that will actually get us through.
Absolutely. Dr. Horton, did you want to provide some comments?
I think it's been said by my three colleagues so far.
Sounds good. Thank you. So the next question we have here is from Garciela, who's asking, how can the tourism sector be better adapted to mitigate COVID-19 impacts as the economy restarts in Canada and in general?
If you want, I could offer a couple of suggestions. So I think it's a difference between what's going to happen immediately and what's going to happen in the longer term. I think, unfortunately, tourism is a sector that's not going to be able to recover very quickly. I've been asked a couple of times, what kind of tourism can we engage in? And my response was, pretend it's the 1950s again, when gas was cheap and you went to drive-in movies. The only difference being that we have the internet now. So, going to cottages, that kind of thing, getting out in your tent, perhaps. But I think, exotic international travel, even though many countries will want to receive tourists, they also do not have the health capacity to deal with any infections that come in. And as we've discussed, asymptomatic transmission is really, really a big issue. And so we don't want to be going to small islands, in the winter to enjoy the sun, because we will be also bringing the virus with us. So, there may be other longer term things we can think about. Maybe the pandemic will lead us to make longer term changes, de-emphasize air travel, perhaps, go back to simpler things. Currently, I think more people are thinking about, going hiking, going out into nature, taking walks every day. Friends of mine put pictures of birds on their Facebook pages. And because I think we have to go back and appreciate some of the more basic things and, forget about going disco dancing in Ibiza.
Yes, that's I don't disagree with anything Sue said, but she better not set foot in the Dominican Republic or any other tourist destination for a few years, because that's precisely what people don't want to hear. And there's so much of the world that is so dependent on tourism that I hope that, and Peter, this is really an important point for you and the UN system and others are going to have to pick up the slack for the countries that are tourist dependent and try to mitigate the impacts. Now, I think there are two other reasons why we won't see tourism, and I can speak very personally on this. I don't like flying because I don't like sitting on airplanes, and I don't like sitting on airplanes in a mask. In fact, I don't think I'm going to do that. The second thing is travelers want to feel safe wherever they go, and I think that's going to take an awfully long time. So I do take issue with the 1950s. You don't remember that. You're not old enough, nor am I. But I do remember those long road trips with my parents, and maybe we're going to see more of that because it's bad for the environment. But what do? I think we really are caught in so many binds and so many contradictions with COVID. It's shone a light, we've lifted the rocks and shone a light under them for us on how we live and how we interact with other people. And everyone on this call, you're going to have to think very seriously about this. Everyone from my colleagues in Waterloo, Kitty Corbett and Craig James and the rest of you, what do? We need to have a salon, perhaps.
Absolutely. So you both ruined my vacation plans. I want to say that out loud. Clearly, I'm not going anywhere for a while. So we do have some time for maybe definitely one question, maybe two. We'll see the answers to the next question. So this question is for Dr. Singer. The WHO has been criticized for their lagged responses regarding mitigation practices. Example, the current website still says to physically distance by 1 meter when studies suggest this is insufficient. Why is this the case? How does the WHO determine what information to disseminate?
You know, with respect, I think the WHO warned early and often about COVID. It first got notification on December 31st, and by January 30th had issued a public health emergency of international concern, its highest level of international emergency, and right through January was issuing guidance within 5 days to the public, to policymakers, et cetera. So I think it warned early and often. I think WHO does, it's a science-based organization, it's a normative organization, and it formulates guidance based on science. And I think the comments Michael made about the evolution of science were very, very thoughtful. And again, you know, my fundamental point is that if these global solutions, global challenges require global solutions, and if WHO didn't exist, we'd have to create it 3 times a week. Dr. Tedros and our colleagues are meeting the world's media, answering questions openly, and I think sharing what they know, what the state of the science is at that time.
Thank you so much, Dr. Singer. So I think we have time for one more question. I'm really squeezing this in. And so based on the WHO's global consultation during COVID-19, can WHO provide leadership role to the global world as we reach the next critical stage of COVID-19 related to reopening of communities and countries? And I'm sure Dr. Singer has some comments around this, but I'd love to also get the other panelists what they think WHO can do in the reopening of our communities.
Maybe I could go last on this one.
Okay.
I'd love to hear what the others think.
So I can say something on that. You know, I think Peter will remember that Dr. Tedros went out of his way on more than one occasion to indicate that he was leery. I think Mike Ryan was the same in giving advice that are the country-specific advice. There's guidance. There's general ways of doing things, but you have to be very conscious about how different countries want to do things. I mean, back to that issue about travel, we see in Europe the significant degree of what they're calling travel bubbles happening. Low infection areas in Germany to low infection areas in Austria or something like in contiguous areas. And that may work well in a situation like Europe. I don't think it's going to work well between Canada and the United States right now. So it's the kind of situation we have to sort of figure out localized approaches, which is why I come back to the point I made earlier about risk communications at the local level. It's so important for people to be able to try to make decisions based on as much information as they can have, so that they can make educated decisions about what, whether it's related to travel or movement or anything that they're doing that they feel they're doing that on some basis of knowledge and information, and can have some confidence accordingly. I think the tourism issue I particularly worry about because of so many countries and economies being dependent on it. We're in this major conversation with the Caribbean right now, who desperately want to have Canadians go back there, and it's really tricky because it's not just going to be a matter of their views versus ours. It's also going to be a matter of what individuals are deciding to do themselves. And for the most part, the demand is, most part, people are saying what others have been saying, Sue and others. They want to stay local because the information they have suggests that that's what they should do. Over.
So if I could just chip in there, Peter, I have to disagree with you. The WHO is a political organization as much as a scientific one. Health is political, and you know from your own reading, Ivan Illich and Paulo Freire, that this is a political issue. We should really be honest about that as we move forward. I just think that we need to put this in the context of a political economy, not just a scientific body. And that's the tragedy of the English response, where we've had Chris Whitty and Patrick Valence, both of whom I know and respect, standing up and presenting us with the answer. Well, tonight Boris Johnson said, no more briefings, which is really interesting.
Dr. Horton, did you want to provide any comments before Dr. Singer responds as well?
Just quickly to say that I don't think WHO is equipped to talk about political economy calculations. Their expertise is scientific and health. And of course, they will understand that it will have implications. But their job is to try and give a dispassionate view of the evidence to enable individual countries to make the best possible decisions. Thank you.
And actually, there's very little that any of my colleagues said to disagree with. Nothing, actually. Obviously, WHO is a member state organization. Imagine having a board of 194 health ministers, and that's the nature of the organization. In our new strategy, which Dr. Tedros announced shortly after we started, one of the key issues is triple billion targets, including one on healthier populations, which for the first time really zeroes down on determinants of health. And so that's a wide range of social, economic, commercial determinants and others. And I certainly wouldn't disagree at all with what Alan said. Health has all these dimensions. I want to really fully concur with what Michael said, how important it is for an international organization like WHO to respect global health expertise in countries, nationally, provincially, and locally. In Canada, we've got some really excellent public health leaders, and public health is local. Context is very important. And so just to fully concur with what Michael said, and of course also agree with what Sue said. Sue made that descriptive statement about what WHO is. And let me just come back to the example I use. So almost every week I have the privilege of listening in on 6 health ministers or senior health officials from 6 different regions in the world, sharing what's happening in their country, what happened, where the virus resurged, and your question was about lockdowns and easing lockdowns, what they did about it. And in one place it's a bar, in another place it's a migrant camp, in another place it's a long-term care facility, in another place it's a meatpacking plant. And just all the governments in the world have the opportunity to learn from each other. And there's only really one organization in the world that can do that, and that's WHO. And that kind of agile, learn as you go, because it's a new virus, is going to be vital to our global response, the international response, but also the response of every individual country. And just to end on the idea of leadership, I think that leadership, multilateralism, and Canada's longstanding support for these things and our own global solidarity is really, really critical. And that, by the way, is I don't know if you'd call it a social or political concept, but there's, global solidarity is if the isolate and track the virus is at the heart of the public health response, global solidarity is really at the heart of the international response, because we will only succeed together. And that's a point Dr. Tedros has made over and over and over again, and I think he's absolutely right.
Oh my God, I wish we had a little bit more time, but I apologize we don't. And I know there are a few other questions, and I apologize again that we couldn't get to them. And so before I pass it on to Anne Fitzgerald, I want to say thank you to all the panelists, Dr. Whiteside, Dr. Singer, Mr. Pearson, Dr. Horton. I've learned a lot just by being, just by listening to you guys here today. So I want to just thank you from the bottom of my heart for sharing some of that knowledge and calming a bit of my own fears. And I'm sure that you know, the audience feels the same, and again, it speaks to how much we need these conversations to continue. And so I'm going to pass it on to Anne Fitzgerald, who is the director of the Balsillie School of International Affairs.
Thanks so much, Dahabo, and just a warm thanks to you as well for navigating us through this excellent discussion so artfully. You did a great job. I'm really heartened, actually, as I look around the checkerboard and I see representatives from international organizations, regional organizations, national organizations, civil society, and the research divisions in the different organizations as well. Because these are the kind of communities and stakeholder bases that are so essential to informed decision-making and evidence-based policy. And Peter Singer, you took the words right out of my mouth about global solidarity. It's essential that we acknowledge that we're in this together. Our response must be one which reflects togetherness. And it's ludicrous to think that we can do anything meaningfully by ourselves and in small numbers. So these are the kinds of small measures that go some way to generating that sense of global solidarity. And in this context, I would really like to echo my thanks to the panelists for making time for this session today. Dr. Singer and Michael Pearson, we really, really appreciate you making time in your afternoon to come in and provide such thoughtful and insightful comments. Indeed, we're extremely proud to have Balsillie School faculty and senior researchers like Professors Susan Horton and Alan Whiteside. Really thanks to the audience for coming in and posing such fantastic questions, which kept this conversation very vibrant and afire. Lastly, I would like to thank Kate White from UNAC and her wonderful team, which together with the Balsillie School has a very productive partnership, a partnership that will go on to have similar interesting discussions like this moving forward. So thank you very much. Over to you, Dahabo.
I'm sad to see everybody go. I'm just going to say that because I thought this was a really great conversation. And I think we are done. I think that you have the rest of the day to yourselves. I hope everyone keeps safe and that you continue to follow some of the regulations to ensure yourselves and your family safe. And I wish you all the very best for the future. And you know, let's continue to do this. I think it's really important that we have these conversations and that that sense of togetherness. That's what stays with me every time that. This is the one thing in my life that everyone knows about and that everyone is dealing with, and I'm not alone in it. I think everybody feels that way. So thank you so much for being part of this conversation, and I wish you all the best. Have a good day, everybody.